Hello and welcome. Today let's go through the most fascinating system, I believe, the endocrine system. So we'll go through chapter 20. Now when we go through and we talk about the endocrine system, we'll see the endocrine system is going to consist of glands and tissues that are going to secrete hormones. This system, the endocrine system, we'll see it can be compared to the nervous system because both of these systems are going to affect other organ systems in maintaining homeostasis. And no other system is really going to do that. So when we talk hormones, I'd like you to know hormones are going to be chemicals, or we can say chemical messengers, that are going to affect the behavior of other glands and tissues, which can be located far from where the hormone is actually produced. Hormones function to help maintain homeostasis by influencing cellular metabolism. They also influence the growth and development of body parts, and they play an important role in how the body is going to respond to stress. Hormones influence other organs also, we'll see here when we go over this table right inside of here. So let's move back. We'll go over these hormones in a few minutes, basically through this whole chapter. That's what we're going to be talking about. And let's go back and let's talk then endocrine glands. Now, when we talk endocrine glands, I'd like you to know endocrine glands are going to be compared to exocrine glands, as we can see here, exocrine glands. Now, endocrine glands compared to exocrine glands. Let's go through and let's check this out. Endocrine glands, we'll see they have no ducts. They're considered ductless glands. Exocrine glands, they actually have ducts. You can see when they secrete their secretions, they're going to secrete their products into ducts. And from the duct, the secretion is going to make its way into a cavity or onto a surface. So here, if we were to draw that out, we would have something like this. We would see this would be, let's say, a gland, and then the gland would have, you can see, here's the surface, right? That's let's say the oral cavity, for example. So here's this gland. This gland's going to have a whole bunch of different cells, and these cells are going to make up a couple of different parts of the gland. One part is going to be, we'll see the secretory part. Now, when we say secretory part, that's going to be the part that secretes, and the other part is going to be the duct. And when we talk duct, and duct is going to be the part that's going to help take these secretions, then we said into the cavity or onto a surface. So here, if we were to draw this out fully, these are all our cells, and these are all the nuclei inside the cells. So here we have the duct, and then here we have the secretory portion. So this is the part of the gland that will actually secrete secretions, and then from here, those secretions are going to all make their way right into here, and then from here, they're going to make their way up. So then when they make their way up, basically right up into here, now they're in the duct, and then from the duct, they're going to make their way out into the surface or into the cavity as we described. So that's what a duct is. Endocrine glands do not have ducts. Endocrine glands, when they secrete, they're going to secrete their secretions into the extracellular fluid, and from there, the secretions are going to make their way into the bloodstream. So the overall picture with endocrine glands is their hormones are going to be secreted into the bloodstream, and they travel through the bloodstream. Here, exocrine glands, their secretions are secreted into a duct, and from there they make their way onto a surface or into a cavity. So when we talk endocrine glands, you can see they secrete hormones. Exocrine glands, they do not secrete hormones. They secrete non-hormonal secretions. They secrete secretions such as saliva, okay, or gastric juice we'll see, or pancreatic juice we'll see that's produced from the pancreas or the stomach. So exocrine glands, non-hormonal secretions. Endocrine glands, hormones. And then third, we can see here, hormones are going to diffuse into the bloodstream, right into the bloodstream. That's a big thing there. Here, they're going to make their way into the duct, and then they're going to go onto the surface or into the cavity. So we talk endocrine glands, ductless glands that secrete their secretions into the tissue fluid. From there, it diffuses into the bloodstream. for distribution. And then exocrine glands, they're going to secrete their products through ducts onto a surface or into a cavity. So one example we can see are salivary glands. And they'll secrete saliva into the salivary ducts, and then from there, the saliva is going to make its way into the cavity, the mouth. So when we talk homeostasis, homeostasis is going to require the cooperation between both endocrine system and nervous system. So here let's compare the two systems to one another. When we talk endocrine system, the endocrine system secretes hormones into the blood. The nervous system is going to transmit nerve impulses. The endocrine system we can see has a slower response. It's going to take a little bit longer to get going. The nervous system, it's got a real fast response. And here the endocrine system, its response is more prolonged. It's got a more prolonged response versus the nervous system, you can see it's got a less prolonged response. It's quick, fast, and it's over. All right, next, then let's move forward. Here we can see now when we talk hormones and homeostasis, the blood concentration of a substance prompts an endocrine gland to secrete its hormones. For example, when we talk parathyroid glands, the parathyroid glands are going to secrete a hormone when blood calcium levels fall below normal. So the parathyroid glands then will secrete parathyroid hormone. And parathyroid hormone is going to help increase our blood calcium levels. And how will it do that? You'll see here there's a response by osteoclast. PTH is going to activate osteoclast, parathyroid hormone. And the response from the osteoclast is to break down bone. And when osteoclasts break down bone, they release calcium. Calcium is released into the bloodstream, and that's going to help increase the levels of calcium. So here then, calcium dropping, you can see, was the stimulus. But now with calcium being released and increasing, that stimulus is going to stop. So this we can see as an example of a negative feedback system. It's going to take time for the response, but it's going to be long lasting. Next, and here we can see the various endocrine glands. Here we can see in this system, all the glands are found scattered basically all over the body. They're not going to be clustered in just one region. So here when we go through the endocrine organs, we can see we've got the hypothalamus, we've got the pituitary gland, we can see the thyroid gland, right behind it are the parathyroid glands, and then here we've got the thymus, we've got our pancreas, we've got our suprarenal glands, our adrenal glands, and then here we've got the male-female gonads, the ovaries and the testes. So let's go through and let's talk first hypothalamus. Let's talk hypothalamus. So we're going to go through all of these glands that we've got listed here, we said, and we're going to talk about the hormone that's going to be released, and we're going to see what it's going to target, and then we're going to see basically what they're going to do there. And then here we've got the chemical class. We can add in there the chemical class. All right, last thing I want to mention to you guys before we jump in is hormones are going to target specific receptors. They don't go and just target any old cell and bind to any old cell. They're only going to bind to cells that have receptors for them. That's kind of like when we talk about our keys. We all have keys. However, only my keys are going to open my door. Your keys will open up your door. So we have hormones. We have lots of hormones. They don't just go and activate any old cell. They only activate cells that have receptors for them. So we can see that right inside of here. Here we can see we've got this one type of receptor. It's a receptor for, you can see a T-shaped molecule, a T-shaped hormone. So here then what binds to it is going to be the T-shaped hormone. This T-shaped hormone can't bind to this receptor on this cell because the shapes don't match. So this hormone is not going to be able to activate this cell. So this cell is a non-target cell. Now the cells that have receptors for the hormone are its target cells. So here we can see when the hormones are released from the bloodstream, they're going to go and target the target cells that have receptors for them because the non-target cells don't have receptors for them. And when we talk about our hormones can be classified into two main classifications. Our hormones can be water-soluble hormones or they can be lipid-soluble hormones. Now, the difference between the two is where they're going to go and bind to their receptors at. Now, when we talk lipid-soluble hormones, lipid-soluble hormone receptors are going to be found inside the cell. So they'll diffuse through the cell's membrane and they make their way into the cell where the receptor is at. Our water-soluble hormones, their receptors are going to be found on the membrane surface. So they're going to bind to receptors on the membrane surface, kind of like what we're seeing here. So this, we could say, is an example of a water-soluble hormone. If it was lipid-soluble, this receptor would be inside the cell, and then that hormone would have to go and diffuse across the membrane, make its way into the cell, and then it could bind to the receptor. So let's move forward then, and let's talk about our hormones. First, let's talk about our hypothalamus. Now, when we talk about the hypothalamus, I'd like you to know the hypothalamus controls heartbeat, it controls blood pressure, it controls hunger, it controls appetite, body temperature, and water balance. It also controls the secretions of the pituitary gland. It also controls the secretions of the pituitary gland. The pituitary gland is going to be a small gland that's connected to the hypothalamus by a stalk-like structure that's called the infundibulum. The infundibulum. The pituitary gland, we'll see, is going to be divided into two parts. It's divided into two parts. First, we've got the posterior pituitary, and second, we can see here we've got the anterior pituitary that we'll go through. So the two parts are the posterior and the anterior pituitary. All right, let's talk more about the posterior pituitary then. Let's talk posterior pituitary. The posterior pituitary, I'd like you to know, is going to be responsible for storing. It's responsible for storing antidiuretic hormone, or it's abbreviated as ADH, as we can see here, and oxytocin. So it's responsible for storing antidiuretic hormone and oxytocin. Now, these hormones, I need you to know, are going to be produced in the hypothalamus. They're produced in the hypothalamus, and they're moved down to the posterior pituitary for storage until use. So when we talk about the posterior pituitary is not a true endocrine gland. The posterior pituitary is technically a storage. It's made up of neurons. It's got, you can see, right inside of here, it's got axons and axon terminals in here. Axons coming down and making their way down into this posterior pituitary. So here you can see we've got nuclei. We've got a couple of different nuclei, and these nuclei are clusters of cell bodies in the central nervous system. They're clusters of cell bodies. These cell bodies then are going to manufacture certain hormones, and they're going to send them down the axons to the axon terminals to where they're going to be stored for use later on. And when they're released, they're going to go and do whatever those hormones do. So that's why we don't call this posterior pituitary a real gland. It's storing hormones that were manufactured in the hypothalamus. We'll see neurons in the hypothalamus are going to monitor water-salt balance of our blood. When the blood is too concentrated, we'll see ADH, antidiuretic hormone, is going to be released. ADH is going to travel all the way down to the kidneys. It travels to the kidneys, and it's going to cause water to be reabsorbed by the kidneys. And when it gets reabsorbed into our bloodstream, helping to increase our water balance. When would we want ADH secreted? When we haven't drank enough water. So instead of releasing all this water from our body and becoming even further dehydrated, we're reabsorbing that water and sending it back and trying to conserve whatever water we can before the individual is able to intake more and help restore their water balance. Next, then, let's talk about oxytocin. I'd like you to know a couple things about oxytocin. I'd like you to know oxytocin causes the uterus to contract during childbirth, and oxytocin is responsible for milk ejection. And it's responsible for milk ejection when the baby is nursing. When the uterus contracts, this is going to lead to more oxytocin's release. So when the uterus contracts, we can see here, oxytocin gets released, and oxytocin is going to act on the uterus. It's going to cause the uterus to contract. When the uterus contracts, the uterus is going to stimulate more oxytocin to be released. With more oxytocin being released, you have more uterine contractions. More uterine contractions, more oxytocin released. More oxytocin released, more uterine contractions. So here you can see we have an example of a positive feedback mechanism. This is different from a negative feedback mechanism that we talked about before. So here we can see we have a waterfall type of an effect. And this will keep happening until the baby is delivered. Once the baby's delivered, then we won't have any more uterine contractions, which won't then stimulate more oxytocin release in relation to the uterus contracting. However, it's still going to be there in relation to the mammary glands and ejection of milk while the baby is nursing. Let's talk then about the anterior pituitary gland. Now, when we talk about the anterior pituitary gland, I'd like you to know that the anterior pituitary gland is going to be producing 6 hormones. It produces 6 hormones I'd like you to know about. Now here, the first hormone we have is going to be TSH. TSH we can see, and that's called thyroid stimulating hormone. TSH we'll see is going to promote the normal development and secretory activity of the thyroid gland. So it's going to ensure we have thyroid hormones being produced. The second hormone I'd like you to know about here is going to be ACTH. ACTH is known as adrenal corticotropic hormone. ACTH is going to stimulate the adrenal cortex to produce cortisol. So ADH is going to get released from the anterior pituitary. It's going to make its way down to the adrenal cortex, where it's going to stimulate the adrenal cortex to produce cortisol. And we'll talk more about cortisol and the adrenal cortex when we get to the adrenal cortex. Next, then, we have gonadotropic hormones. Our gonadotropic hormones will include FSH and LH. FSH stands for follicle stimulating hormone, and LH stands for luteinizing hormone. Luteinizing hormone. FSH and LH are going to stimulate the gonads. They're going to stimulate the testes in males and the ovaries in females to produce gametes, which are sperm and ova, and also to produce sex hormones. So we've got 1, 2, 3, 4 hormones from the anterior pituitary taken care of. And then the last 2 we can see here, we've got growth hormone and prolactin. Let's talk prolactin. Prolactin is going to be produced during pregnancy and after childbirth. Prolactin is going to cause the mammary glands to develop, also to produce milk, and it's involved in the suppression of ovulation in nursing mothers. Our 6th hormone is going to be growth hormone. Growth hormone is abbreviated GH. Growth hormone is going to promote skeletal and muscular growth and fat metabolism. There's a seventh hormone I would like you to know about here, and that seventh hormone is called MSH, melanocyte stimulating hormone. Melanocyte stimulating hormone causes skin color changes. It causes skin color changes. All right, next then let's talk about the thyroid gland and the parathyroid glands. Now, when we talk about the thyroid gland is going to be a large gland that's found located in the neck. It's attached to the trachea, and it's found located just below the larynx. Now, when we talk about the parathyroid glands, they're going to be found embedded in the posterior surface of the thyroid gland. So if we move back to this picture of all of our endocrine glands, you can see the thyroid gland in the anterior neck on the trachea, just inferior to the larynx. And here we can see it's taking on the shape of a letter H, or you can say it's kind of butterfly shaped. So here you can see that much better. But we're looking here in this picture at the posterior aspect of it. This is the back of it. Right here is the front of it. So on the back of it, on the posterior aspect, is where you're able to locate the parathyroid glands, as you see here. So we can see here then when we talk about our thyroid gland, the thyroid gland is going to be made up of spherical structures that are going to be called follicles. Each of these follicles are going to be made up of thyroid cells, and the thyroid cells produce triiodothyronine and thyroxine, our two thyroid hormones. Triiodothyronine you can see is abbreviated as T3, and thyroxine is abbreviated as T4. The difference between the two is one iodine atom. T3 has 3, T4 has 2. So you could see here, we require iodine. Thyroid requires iodine to produce these hormones. If we have iodine deficiency, this can cause a simple goiter to occur in the patients, or you can see an enlargement of the thyroid gland. That's what goiter is. It's an enlargement of the thyroid gland. So if we don't have enough iodine, you can see the patient can develop a goiter. We get our iodine from our salt or seafood. Next, when we talk T3 and T4, these hormones, they're going to increase our metabolic rate. We can see here they increase our metabolic rate. These hormones, they stimulate most of our body's cells to metabolize glucose and to utilize more energy. Next, then we have calcitonin. The thyroid glands also produce calcitonin. Calcitonin is a calcium regulating hormone. It's going to be produced in response to increased blood calcium. So if we have increased blood levels of calcium, calcitonin comes into the picture. And calcitonin causes the uptake of calcium by bone. Calcium, we can see, is very important. Calcium is going to be important in muscle contraction, in nerve conduction, and in blood clotting. Next, let's talk our parathyroid glands. Now, when we talk about our parathyroid glands, we usually have 4 in quantity. And as we saw before, they're found on the posterior aspect of the thyroid gland. Our parathyroid glands, they secrete parathyroid hormone. It's abbreviated as PTH. Now, parathyroid hormone, or PTH, functions to increase blood calcium levels and to decrease phosphates. So PTH is going to cause an increase in our blood calcium. So if our blood calcium levels happen to go low, PTH comes into the picture. What did we say? Which hormone did we say is going to come into the picture if calcium levels go too high? Calcitonin. So you can see calcium is going to be regulated to a precise level. So if we don't have enough calcium, PTH is going to come into the picture, and PTH is going to cause an increase in blood calcium and a decrease in our blood phosphate levels. Now, how does PTH increase our calcium? PTH is going to increase our calcium 3 different ways that I would like you to know about. One will be through the kidneys. Second will be through our intestines. And the third is going to be through our bone. So let's go through each of them. First, when we talk, here we can see how does PTH increase blood calcium and decrease phosphate? We can see it's going to increase osteoclast activity and it's going to increase the reabsorption of calcium by the kidneys. Also, it stimulates the activation of vitamin D that's going to be needed for calcium absorption in the digestive tract. So you can see here it's also going to help increase its absorption in the digestive tract as well. And then we can see when blood calcium levels increase, PTH is going to be shut off. So this was an example of a negative feedback mechanism. Now let's go through and let's check out the regulation of blood calcium levels. So here we can see if we have high blood calcium levels, our thyroid gland is going to secrete calcitonin. Calcitonin, we said, is going to cause our bones to take up calcium from the blood. This decreases the levels of calcium in the blood, taking us to homeostasis. Now, if we have low blood calcium, then our parathyroid glands are going to release parathyroid hormone, PTH. When PTH is released into the bloodstream, PTH is going to make its way over to our bones. And when it makes its way over to the bone, it's going to cause calcium release by activating our osteoclast. The osteoclast break down bone, releasing calcium into the blood. When we talk kidneys then, PTH is going to make its way over to the kidneys and it's going to cause the kidneys to reabsorb calcium. And when they start to reabsorb calcium, this calcium gets returned to the bloodstream, again helping to increase the levels. And then our activated vitamin D is going to cause the intestines to absorb calcium from the digestive tract, again helping to increase calcium in our bloodstream, causing our blood calcium levels to rise, taking us back to homeostasis. Next then, let's move over to our adrenal glands. Now we talk about our adrenal glands are going to be found sitting on top of the kidneys. They're also known as the suprarenal glands. Right? The prefix supra means on top of the kidneys. So suprarenal, renal is in reference to the kidneys. So they're found seated on top of the kidneys. Each gland is going to be divided into an inner portion that we call the adrenal medulla and an outer portion that we call the adrenal cortex. Now, these two parts of the adrenal gland are going to function independently. So here we can see the adrenal medulla. It says outer portion, it's the inner portion. The adrenal cortex is going to be the outer portion. Now, when we talk about the adrenal medulla you can see is going to be under the control of the nervous system. And the adrenal cortex we can see is going to be under the control of ACTH, which is going to be an anterior pituitary hormone. All right, next then let's talk about the adrenal medulla then in greater detail. Now, when we talk about the adrenal medulla, I'd like you to know first the hypothalamus initiates nerve impulses by way of the brainstem, the spinal cord, and sympathetic nerves to the adrenal medulla. The adrenal medulla secretes two hormones, epinephrine, which is also known as adrenaline, and norepinephrine. Epinephrine and norepinephrine are going to bring rapid short-term changes. They help respond to stress. They initiate that fight or flight response. Now, when we say they're involved in this fight or flight response and they're responding to stress, here what they're going to do is they're going to get the heart to start contracting faster. They're going to cause the lungs to have a bronchodilation and our pupil to be dilated, all helping in the fight, so we can fight, or flight, we can take off, response. This is our response to stress. Very important. All right, next then let's check out the adrenal cortex. Now, when we talk about the adrenal cortex, you'll see its hormones are going to result in long-term changes. The two hormones I want you to know about here are going to be glucocorticoids and mineralocorticoids. Glucocorticoids, they regulate carbohydrate, protein, and fat metabolism, leading to an increase in blood glucose levels. So you can think of glucose, glucocorticoids. Glucocorticoids are going to help increase blood glucose levels. Next one, we have our mineralocorticoids. Our mineralocorticoids, they're going to regulate salt and water balance, leading to an increase in blood volume and blood pressure. So you can think mineral and then minerals. So let's talk first glucocorticoids. Now, when we talk glucocorticoids, the most important glucocorticoid you are going to have to know about is going to be cortisol. Cortisol is the principal glucocorticoid hormone that's stimulated by ACTH. ACTH you saw coming from the anterior pituitary. So it makes its way over to, we said, the adrenal cortex, and you can see here it's going to help release cortisol. Now, when we talk about the actions of cortisol, you can see cortisol functions to promote the breakdown of muscle proteins to amino acids. And then we can see the liver is going to use amino acids to make glucose. It promotes the metabolism of fatty acids. You can see sparing glucose. So overall, it promotes a rise in blood glucose, which is beneficial under stress. We can see also here cortisol counteracts the inflammatory response. It can also suppress the immune system. Now we talk mineralocorticoids. Mineralocorticoid secretion is not controlled by the anterior pituitary. Now the most important mineralocorticoid I want you to know about is aldosterone. Aldosterone is the principal mineralocorticoid hormone that targets the kidneys. What it does is it increases the absorption of sodium and the excretion, the removal of potassium. It's also going to regulate blood volume and pressure, because we'll see wherever sodium goes, water follows. So if we're having an absorption of sodium, water follows it. Now with water following it, what's that going to do to our blood volume? That increases the blood volume. Now when we increase the blood volume, that obviously is going to increase the blood pressure as well. The secretion of aldosterone is going to be controlled through the release of renin from the kidneys. Now when we talk about renin, we can see renin is going to be released when our blood sodium levels and our blood pressure are low. So if we have low blood sodium levels and low blood pressure, this is going to stimulate the release of renin. What renin does is it's going to activate angiotensinogen. So it converts angiotensinogen to angiotensin 1. Angiotensin 1, we'll see, is going to get converted to angiotensin 2. It gets converted to angiotensin 2 by this enzyme that's produced by our lung capillaries. And that enzyme is called ACE, angiotensin converting enzyme. ACE is the abbreviation, ACE, angiotensin converting enzyme. So it converts angiotensin 1 to angiotensin 2. Angiotensin 2 then is going to stimulate our adrenal cortex to release aldosterone. So you can see everything that's involved in helping to get angiotensin 2 released, so that way it can stimulate the adrenal cortex to release aldosterone. And then aldosterone, we saw, is going to help increase the absorption of sodium, which increases blood volume and increases pressure. Here we said renin is going to be released when blood sodium levels and blood pressure are low. So helping to resolve this problem. When we talk about the effects of angiotensin 2, so not only does angiotensin 2 work with aldosterone in helping to increase blood pressure and all that as we saw, but it's also going to constrict our arterioles. It constricts our arterioles. Another hormone here that I'd like you to know about, ANH, atrial natriuretic hormone. Atrial natriuretic hormone is going to be produced when the atria of the heart are stretched. And that represents an increase in blood volume. So what's the response going to be? It's going to be to inhibit the release of aldosterone, which results in natriuresis, the removal of sodium through the urine. And what's going to follow sodium? Water. When water follows sodium, that's going to cause blood volume to go down, therefore pressure decreases. So let's check this all out here in this picture. Here we can see if we're in homeostasis, we have normal blood pressure. But if we have high blood pressure, you can see the heart's going to secrete ANH. ANH then is going to cause our kidneys to excrete sodium and water into the urine. And that's going to cause our blood pressure to drop, taking us to homeostasis. And now we can see if we have low blood pressure. If we have low blood pressure, the kidneys are going to secrete renin. Renin then converts angiotensin 1 to 2. Angiotensin 2 then is going to release aldosterone. Aldosterone, we said, is going to cause the kidneys to reabsorb sodium and water from the kidneys' tubules, causing blood pressure to rise, taking us back to homeostasis then. So let's check out our response to stress, and then we'll move on to the pancreas. Now, when we talk about our response to stress, we have two different responses. We have short-term response, and we have long-term response in case that stress is not going away. So first we can see here stress comes in. Stress will cause the hypothalamus to send impulses to the spinal cord, which will then send impulses along the sympathetic fibers to our adrenal medulla to help release epinephrine and norepinephrine. Epinephrine and norepinephrine are going to cause our heartbeat and blood pressure to increase. They'll cause our blood glucose levels to rise, and they're going to cause muscles to become energized. Now, in long-term stress, what's going to happen is, since the stress is not going away, our neurosecretory cells are going to produce hypothalamic releasing hormone. Hypothalamic releasing hormone is going to help release ACTH. ACTH then is going to help release glucocorticoids and mineralocorticoids. Our glucocorticoids, we can see in our long-term response to stress, they're going to be involved with protein and fat metabolism instead of glucose breakdown. And we can see we'll have a reduction of inflammation, and our immune cells are going to be suppressed. Mineralocorticoids are going to cause sodium ions and water to be reabsorbed by the kidneys. This is going to increase blood volume and pressure. So we can see here in our long-term response to stress, not only are we going to have blood pressure going up, but you can see our immunity is going down as well. So it's not good, not good. Let's move forward then. Let's move to the pancreas. Now, when we talk about the pancreas is going to be an organ that's going to be found lying in the abdomen near the duodenum of the small intestine. The pancreas is composed of two types of tissue. We have exocrine tissue and endocrine tissue. The exocrine tissue is going to secrete digestive enzymes, and they're going to be released into ducts, which will take them into the small intestine. Now, the endocrine component is made up of pancreatic islets. So the pancreatic islets are the endocrine portion of the gland. There are three types of cells in the endocrine islets. The first type are our alpha cells, and our alpha cells are going to produce glucagon. The second type are our beta cells. The beta cells we'll see are going to be responsible for producing insulin, and insulin is very important in the regulation of blood glucose levels. And then third type are our delta cells. Our delta cells, they produce somatostatin. So let's check out these hormones then in greater detail. Now, when we talk insulin is going to be released after eating. When our glucose levels increase, that's when insulin is released. Insulin is going to stimulate the uptake of glucose. It's going to stimulate the uptake of glucose by our cells, especially muscle liver and adipose cells. It causes a decrease in our blood glucose levels. Now, when we talk glucagon, glucagon is going to be released before eating when our glucose is low. So during periods of fasting, glucagon is going to help release glucose to keep glucose levels at an adequate level. Because again, too much glucose is not good because too much glucose wreaks havoc on our tissues. So insulin is going to be important in helping to bring that level down. But then if we don't have enough, that's also going to be important because we're not going to have any energy. We saw how glucose is going to help give ATP, all that energy we saw. So glucose is released thanks to glucagon during periods of fasting. Glucagon targets our liver and our adipose tissue to release glucose, and it helps to increase our blood glucose levels. So here we can see if we are in homeostasis, we're fine. However, if we have increased blood glucose levels, if our blood glucose levels are too high, if our blood glucose levels increase, let's say for example after eating, insulin then gets secreted. We can see first, insulin is going to cause our liver to store glucose from our blood as glycogen. Second, we can see our muscle cells are going to store glycogen and build proteins. And then third, we can see our adipose tissue uses glucose from our blood to form fat. And all of these three processes will cause our blood glucose levels to drop, taking us to homeostasis. Now, if we have low blood glucose levels, then here we said our pancreas is going to get stimulated. The pancreas then is going to secrete glucagon into our blood. Glucagon is going to make its way over to our adipose tissue, breaking down fat, releasing glucose. Also makes its way over to the liver, breaking down glycogen to glucose, and glucose also enters the blood, helping to increase our glucose levels, taking us to homeostasis. We have another hormone here that I'd like you to know about in relation to the pancreas, and it's called somatostatin. Somatostatin is also known as growth hormone inhibiting hormone. Somatostatin is also produced by cells in the stomach and the small intestine. Its main effects include to inhibit the release of growth hormone by the anterior pituitary, and it's going to be involved in suppressing the release of various hormones that are produced by the digestive system, including insulin and glucagon. All right, let's move on then to our other endocrine glands. Now we talk other endocrine glands. First, we'll talk about our gonads here. The gonads are going to be the testes in males and the ovaries in females. The gonads are going to be endocrine glands. These organs are obviously the gonads, so they do their respective job there, but they're also endocrine glands. There are other glands and certain tissues that also produce hormones we'll see in the body. So let's talk first testes. The testes, they produce sperm and they produce androgens, but we're here to talk endocrine, so we're not talking sperm production. We'll do that when we get to the reproductive system. We're talking androgens. Androgens, the most important androgen I'd like you to know about, testosterone. We talk testosterone, so androgens or testosterone we can say is going to be responsible for male secondary sex characteristics, which includes beard growth, the enlargement of our vocal cords and our larynx. Androgens will also stimulate oil production by our oil glands. Testosterone is involved in pattern baldness, and testosterone is responsible for increased muscle development. Now, when we talk testes and ovaries, we'll see some athletes take supplemental amounts of illegal anabolic steroids, and this can include testosterone or other related chemicals. Now, there's many side effects from taking anabolic steroids, including acne, body odor, and baldness. Next, let's talk about the ovaries. The ovaries, they produce eggs, they produce estrogen and progesterone. Again, we won't talk about eggs, so we're here to talk estrogen and progesterone. Estrogen, now we can see it stimulates the growth of the uterus and the vagina. It's required for egg maturation, and it's responsible for the secondary sex characteristics in females, which includes breast development along with progesterone, and then fat distribution, and the appearance of body hair. Now, when we talk progesterone, progesterone is involved in the regulation of the uterine cycle along with estrogen. Next, then, let's talk about our thymus gland, and then we'll check out the pineal gland as well. The thymus gland is going to be largest and most active during childhood. And as we age, as we get into adulthood, it gets replaced by fatty tissue. The thymus gland is going to secrete thymosins. Thymosins are going to be hormones that are involved with the maturation of T lymphocytes. Next is the pineal gland. The pineal gland produces melatonin. Melatonin, we believe, is involved with regulating our sleep-wake cycles and our circadian rhythms. All right, next, then I'd like to talk to you about growth factors. Then we'll jump into some pathologies. When we talk growth factors, they're going to stimulate mitosis in tissues. Some are going to be released in blood, while others are going to act locally. The first one I'd like you to know about is granulocyte macrophage colony stimulating factor. It's produced by many different tissues, and it causes bone marrow stem cells to produce granulocytes and macrophages. Next, you have platelet-derived growth factor, which is involved with wound healing. And then last, we have epidermal growth factor and nerve growth factor, which are also involved with wound healing. All right, let's check out then some disorders in relation to the endocrine gland. And we'll start off first with disorders of the pituitary first. Here we have first diabetes insipidus. In diabetes insipidus, the posterior pituitary secretes too little ADH, too little antidiuretic hormone. So here then, with too little ADH, we'll see large amounts of urine are going to be produced, resulting in dehydration. Next in here we have pituitary dwarfism. In pituitary dwarfism, the patient has too little growth hormone that gets secreted by the anterior pituitary. This condition is characterized by small stature but normal proportions. Next then, let's check out gigantism. Gigantism is a disorder where you have excessive growth hormone that gets produced during childhood. Gigantism also promotes the development of diabetes mellitus. So here we can see a young man with gigantism, and then we have a young man here with pituitary dwarfism. And then the last disorder I'd like you to know about, also in relation to growth hormone, is acromegaly. Now, acromegaly is excess growth hormone in adulthood. So this is after the growth plates have closed. Okay, so we're not going to have linear growth here, we'll see. So excess growth hormone in adulthood. Long bones cannot grow. So the effect is noticeable in the hands, the feet, and the facial bones. So here you can see this patient at the age of 9 is normal height, 16 normal height, and then 33, here you can see this patient starts having widening of certain features. And then at 52, you can see the size of the hands, the eyebrows, the forehead, and the size of the head all being affected there. In order to diagnose this condition, we'll do exactly this. We'll ask the patient to bring in a few pictures, and we'll put all the pictures together, and we'll understand then when the growth actually took place. All right.